Good morning, everybody. My name is Michael Cooper. I'm the former chair of the Paediatric Anaesthesia Committee for the WFSA, and I'm very pleased to be here and presenting this talk. I just wanted to thank a few people first. Firstly, the WFSA. Secondly, Vladimir Cherny and the rest of the scientific committee for this meeting, and indeed the whole Czech Society of Anaesthesiology and Intensive Care Medicine. And also, lastly, Jacob Novak and the rest of the team at Garant International. I don't think there's ever been an international meeting where it's been harder to actually get a meeting organised globally like this, and I commend them all. And lastly, I would also like to thank all the paediatric speakers who've agreed to talk in the various paediatric sections of this meeting. So my talk today is where is the child in global safe anaesthesia and surgery? And as we'd all know, about 6 years ago, it was a very pivotal year for a couple of reasons. We had the Lancet Commission on Global Surgery, we had the disease control priorities from the World Bank and the WHO Assembly resolution. And as you can see from that diagram on the left, looking at access to safe surgery, there was this band across the middle of the world from Central and South America, across Africa to Southeast Asia and leading into the Pacific. And there are a lot of key messages that came out of the Lancet Commission, hopefully leading up to 2030, about the number of people who lack access to safe, affordable surgical anaesthesia care, the amount of unmet surgery that was needed, the expense to the patients and their families, and what this investment in safe surgery and anaesthesia will save. And the bottom line, that surgery and anaesthesia are an indivisible and indispensable part of healthcare. There's been a lot of progress since those last 6 years. We've had the safe surgery checklist become much more established around the world. The WFSA has become the go-to organisation with the World Health Organization. And the WFSA represents 95% of physician anaesthesiologists around the world. They've implemented the Anaesthesia Workforce Survey. There's the International Standards for Safe Practice of Anaesthesia that came out just on 3 years ago. And interestingly, and from our point of view, paediatric anaesthesia is the largest and most enthusiastic, I think, subgroup within the WFSA. There's been a lot of other initiatives. Individual countries are rolling out national surgery, obstetrics and anaesthesia plans. NGOs like Lifebox, who are now 10 years old and have distributed an enormous number of oximeters. And this has never been more important than through the current pandemic. Even the international standards for the safe practice of anaesthesia have very specific requirements for children. And we all know in looking after children under 10 kilos, monitoring and equipment is exceedingly important. Now, there were quite a few indicators that came out in the Lancet Global Commission that were relevant to children. And certainly access, the number of specialists and the surgical volume were all important, as were the other indicators. One of the things I want to look at is the paediatric perspective to all of this, and where are the children in all of this? And this data about the realisation of Children's Rights Index, which was set up a couple of years ago, and looking at all the various factors you can see there on the left of the screen, shows again this similar band across the world from Central and South America, across to Africa, Southeast Asia and into the Pacific, of children who are in difficult or very serious situations for all these risks to their daily life. So what do we know about paediatric demography in the world? Well, there's nearly 400,000 babies born every day. That's 140 million children a year. There is about 2.2 billion children in the world, and we're nearly at the 8 billion population. And a lot of these children are in the developing world. A quarter of the world's population is less than 15 years old. In high-income countries, it's about 15 to 20% of the population. But in the low middle income countries, it can make up 45% of the population. We all know that global surgery, a tiny percentage, only occurs of surgery in those LMICs. If you look at paediatric injuries in LMICs, there are over 20 million injuries per annum. and nearly 1 million children die per annum from injuries. Children have a unique place in every society. They can often be marginalised in low resource settings. They depend very much on their parents. They can't advocate for themselves. We all know that children have less physiological preserve and will often present with their illnesses and surgical conditions in an extremely late setting. Just where you're born in your family will affect your survival. In many countries, you have a higher mortality rate if you're sibling number 4 or greater. If your mother dies and the child is less than 5 years old, then they're 4 times more likely to die and 50 times more likely if they're less than 1. Children have less access to health care than adults, and often the appropriate care is not available. And there can be a huge backlog of treatment, especially for things like congenital anomalies. And interestingly, the difference in funding for healthcare of children in high-income countries versus low to middle-income countries is 100 times. We know the spectrum of paediatric disease is changing, and it's very different in low middle-income countries compared to the HICs. HICs have much more advanced medicine, better antenatal care and screening, and we see there's a lot of conditions that we're seeing less of in more developed countries. The under 5 mortality rate is slowly improving across the globe, but certainly not to the Millennium Development Goal 4 requirements. And now congenital anomalies account for about 1/3 of all infant deaths. We do see some natural selection. Children with congenital diaphragmatic hernia, tracheoesophageal fistula rarely survive in low resource settings. The workforce can vary. We have many specialists in high income countries, and in children, where most of the children in the low income countries, they're cared for by a few who are often very inexperienced in advanced care. Everyone is aware of the bellwether procedures from the Lancet Commission, and those 3 arrows show cleft lip and club foot repair, and one of the lowest ones is actually neonatal surgery. We all know that is one of the most challenging areas, and at the time the Lancet Commission said neonatal surgical conditions either need urgent surgery locally or after transfer. And this is surgery like colostomy or bowel resection, not easy operations. And we know that very rarely can these babies get transferred out, and they're often left with poor resources and inexperienced practitioners trying to care for them. So how do ordinary hospitals cope with paediatric surgery in these resource-poor countries? This study from Zambia a few years ago found that 14% of over 100 hospitals there met the minimum paediatric surgical safety criteria. If you're in a city, about 1/3 did, but if you're in a rural hospital, only 2% did. Children only accounted for 16% of the operations, but nearly half of the population. And the big limitation was the lack of surgical and anaesthetic skill for doing the difficult things, neonatal colostomy, abdominal wall defects, burns, and so on. Neonatal anaesthesia has a high mortality in many countries. This data is 20 years old, and you just have to scan across it to see how bad it was. And in some areas, there has been no change to this in 20 years. Trauma affects children enormously, and we all know that in any society. And all the normal things that you can see occur everywhere. Interestingly, in the 20 years to 2015, over 10 million children under the age of 5 died as a direct consequence of conflict. I would recommend to you looking at the website for the Global Initiative for Children's Surgery, or GICS as it's known. And this infographic sums up all these sort of demographics I've been talking about. Up to half of the people in the world are children. 2/3 of the world's children lack access to surgical care, which is estimated to be 1.7 billion children. And injuries alone will kill more children globally than HIV, TB, and malaria combined. GICS have some superb resources available, and their optimal resources is an excellent starting point for developing paediatric surgical resources in any country. Many countries will never have appropriately trained specialist paediatric surgeons and anaesthetists, and so it becomes the realm of the common specialist, the common anaesthesiologist or surgeon. The physiology and pathology of paediatric disease is entirely different to adults, as we all know, and it needs to be factored into the training of general specialist surgeons, anaesthesiologists, and other anaesthesia providers. The WFSA workforce map has been outstanding, and again you can see that coloured band that goes across, as I mentioned before, from Central and South America to Africa to Southeast Asia and well into the Pacific, looking at the number of providers available in these countries. And you compare that to the high-income countries. The challenges for us are in training, and we need to train anaesthesiologists at several levels. We need to train paediatric anaesthesiologists, so they're a national resource for each country. We need to train general anaesthesiologists to have paediatric expertise because they will have to cope with these difficult situations. And in many countries and many parts of the world, we have nurse anaesthetists or non-physician anaesthesia providers who will often be providing significant paediatric anaesthesia care and often in remote settings with the least support. And we need to attack this at all levels. Children, we know, are more likely to suffer any of the delays in terms of access to surgery. Depending on parents and family support, there may be significant delay in them seeking care. There may be delay in them reaching care, and this photo is actually of a woman in obstructed labour in Papua New Guinea being swum across a river to get to a small provincial hospital. And then when they get to that small provincial hospital with very limited resources, there may well be significant delay in receiving care. I now think we've got a fourth delay, and as we all know, the pandemic has impacted enormously on everything. The provision of surgical services in all countries, the loss of healthcare workers, especially the SAOs, the surgeons, the anaesthesiologists and the obstetricians, and these are already at critical levels pre-pandemic. So children are much more at risk. Interestingly, in The Lancet last week, there was an article saying there are an additional 1.5 million orphans in the world just due to COVID. And this obviously means that they will have less access to appropriate healthcare. So there is no doubt how much COVID has subverted global health. We know that some of the funding for reproductive, maternal, newborn and child health was dropping off a little bit before the pandemic, and obviously the pandemic will have had a major influence on this. We know that COVID-19 has had a huge influence on the practice of paediatric anaesthesia. There will be none of us at this meeting who it would not have impacted in some ways, and for many very significantly. Things like cancer care in low and middle income countries, it's had an enormous effect in unavailability of agents, treatment abandonment, and interruptions to radiotherapy. There is a light at the tunnel. Certainly there is another Lancet Commission for paediatrics that was released last year, and was led by Helen Clark, her foundation. Helen Clark's the former Prime Minister of New Zealand. And I commend this to any of you who are in a position within your country or your region in terms of the development of care and appropriate safe surgery and anaesthesia for children. Just a few weeks ago, there was a new initiative to support this Paediatric Lancet Commission, that children be included in all health policies up to 2030. And this is an important new development. The next challenge for all of us in paediatric surgery is congenital anomalies. And I recommend you have a look at this editorial recently from The Lancet. That 6% of children have a congenital anomaly. 94% are born in low middle income countries. And we know how much of the world's children lack access to appropriate surgery. Many countries have less than one paediatric surgeon per million children, and even less paediatric anaesthesiologists. In this study, they looked at the mortality from the major congenital anomalies, and they looked in a very broad fashion, nearly 4,000 children, 74 countries, and over 250 hospitals, the majority of which were for low and middle income countries. And they looked at the diagnosis, treatment and outcome of some of the major paediatric diseases that we all see on a regular basis. And the numbers were large. When you look at the mortality alone from these countries, the low-income countries for these conditions in children had a mortality of 40%. If you're in a middle-income country, it was 20%, and high-income countries just under 6%. Things like gastroschisis, esophageal atresia, and even intestinal atresia had very high mortalities in the low-income countries. There was also increased mortality with sepsis, high ASA classification, the lack of post-operative ventilation and parenteral nutrition, which exists in many low and middle-income countries, and an absence of a physician anaesthesiologist. And interestingly, even something as simple as a safe surgical checklist not being used increased the mortality. So even these simple things can make an enormous difference to the care of a child undergoing surgery. So what do we do in the future? Well, we need to train our colleagues in all LMICs to manage major paediatric surgery. For short-term missions, there will always be some of the clinical challenges, and I'll talk about that in a moment. Teaching and training is the most important thing that we can do, and there are many aspects to this. The WFSA Paediatric Anaesthesia Fellowships we hope will recommence as the pandemic settles. Many of the national anaesthesia paediatric societies, SPA, JSPA, all run different fellowships within their region. There are many short-term courses that can be implemented. Safe Peds, Safe OR, all are very important for a few days with in-country teaching. Online education since the pandemic has become regular, effective, and beneficial, and there are major initiatives happening with that all around the world. Our partnerships need to continue. Our involvement in strengthening surgical care systems through the National Surgical, Obstetric and Anaesthesia plans is really important. And as always, networking and our collegiality and sharing resources makes a huge difference. We do need to train our colleagues. You need to have about 4 paediatric surgeons per million children to get a better than 80% survival in the following 4 paediatric bellwether operations. And these are like intestinal atresia, bowel perforation from typhoid, abdominal wall defects, and esophageal atresia. We mentioned earlier the paucity of anaesthesiologists in many of these countries, and to get to the minimum target of even 20 SAOs per 100,000 could prevent more than 600,000 children dying each year under the age of 5. So even for surgeons, this is an extra 7,000 paediatric surgeons in low middle income countries. I mentioned about short-term clinical missions, and there's a lot of pros and cons, and I would commend to you these 2 editorials that have been in paediatric anaesthesia recently. There are a lot of pros of short-term missions, especially if they are followed up on a regular basis, in that there is added expertise and equipment, things like paediatric cardiac surgery and craniofacial surgery, types of surgery that a country may never have, but is able to address the needs of their children if a team is able to come and do it. Financially, you get better bang for buck if a team can come in and operate on children rather than trying to repatriate children to other countries for their surgery. You can get better numbers of people taught and teaching locally, and you establish long-term relationships. But there are a lot of criticisms of these, and I think we have to take these into consideration, that some of this volunteerism may be misguided. There are elements of neocolonialism. Often some countries will see this as a reason to fund their own healthcare within the country less because of outside funding coming in. And with a lot of these missions, one size doesn't fit all and will depend very much on the country, cultural needs and availability. And it may be better in the longer term to redirect some of this funding to advance training for local trainees. There are a lot of areas since the pandemic has kicked off with oxygen and oximetry, and we know about the huge need for the measurement and management of hypoxia from COVID and other pneumonias in children. And there is no doubt that anaesthesiologists can lead in these areas. Simple initiatives of oxygen concentrators, oximeters, can make an enormous difference to outcome with a 50% improvement in mortality. There are many meetings coming up, and we can do all of these online like this. And it's important to have input into all of these meetings. Interestingly, our one at Spanza in Sydney coming up in a few months is combined with our paediatric surgeons, as is the SPA meeting next year, in April is with their paediatric surgeons. And I think there's a huge need to have global health with the surgeons and the paediatric anaesthesiologists in regular sessions at these meetings. There are also things like the WhatsApp group, which has been very successful, and little apps like PD Crisis as well. So remember, all of this has just been to show you that the anaesthesiologist is really now a global health physician. And I think more than ever, the paediatric anaesthesiologist is a global health physician. So remember, when we're caring for children, we have the support of our national anaesthesia societies and certainly our paediatric anaesthesia societies, who do enormous jobs in various regions around the world. They really are fantastic. And there are many other groups out there and NGOs who have significant input into the care of children in the world. And I commend all of them to you. Everybody is doing their bit. So I'd just like to thank you for this. And this opportunity to speak to you. And I would also mention that my successor with the Paediatric Committee of the WFSA is Nori Furatani, who has got a big job in front of him. Nori is a paediatric anaesthetist at Saitomo Children's Hospital in Japan, and please give him all your support. So thank you very much, and I wish you all well.